Varun, thank you very much for that introduction. I wondered if you were really speaking about me or someone else, but there's always a danger when you introduce a speaker in that flowery a fashion if the lecture actually doesn't match up to the expectation. You know, I know that this audience is capable of making some noise. Hopefully, it's for all the right reason. So, the first slide actually thanks you, and I thank the organizers for inviting me to speak before you today. It's actually a singular honor for me to be able to come back to the place where I learned the basics of pediatrics from real luminaries. And Dr. Manglani, my teacher, is here, and I know she's been instrumental in having me come over here, so thank you very much. And I'm also particularly delighted to be able to speak about a subject that's close to my heart, the subject of pediatric cardiology, in what is actually the National Heart Month in the United States of America. It might have something to do with Valentine's Day, but that's okay. All right. Now, during the course of this talk, I would like to introduce to you the wide world of pediatric cardiology and what it is that we can offer as pediatric cardiologists to our patients. Of course, the basic aim is to kindle the same enthusiasm that I have for my field in some of the bright sparks that I see in this room out here and back in the backstage out here, because really what I want to do is continue to attract the best and brightest to my subspecialty. I know that the competition is fierce with Dr. Manglani and Dr. Ratna Sharma in the audience, but we'll try and get the best students to join pediatric cardiology and not go and do hematology instead. It's a tough fight, but we'll try and do that. Okay. All right. But somewhat more important actually is to shine a light on what is being done in India and what can be done in the years to come, because we have the unique setting of somewhat limited resources, though that's not actually very true in this day and age. And definitely there is significant demand. So is there something that needs to be done a little differently so that the unique needs of the Indian environment can be accommodated in aiming to bring pediatric cardiac services to India? All right. Now the question that I sometimes get asked, let me veer a little away and say that the thing that gives me the most pleasure is interacting with medical students, and I'm not sucking up to you out here, okay? I'm a mentor to medical students at Mount Sinai School of Medicine. It's one of the top 20 schools in the whole of the United States, and the caliber of the medical students is truly extraordinary. They do come up to me, and I've mentored them over the past few years, and the question that they sometimes ask is, why did you go into the field of pediatric cardiology? So very early in my career, I figured out that I really had no particular talent for abstract thinking. So areas like neurodevelopment, pediatric psychiatry, all of those were out for me. Okay. Now, much like the plumber in this cartoon, I was home with blockages. Now, if there are blockages in the pipes, in the US you have to kind of do it all on your own, of course. Plumbers are more expensive than doctors. All right. So if there are blockages in the pipes or within the heart, I was at home with them. And the dictum is simple. If things get blocked, there's trouble, unless you can relieve the blockage. I was also fairly comfortable with electricity. So in short, I was a little bit like these regular Joes that you see in this picture. Of course, if I looked anything like them, I'd probably try my luck in the movies, but I don't. So I had to be satisfied with cardiology, because if you understand plumbing, and if you understand electricity, half your battle is won. You're already on your way to becoming a pediatric cardiologist. All right. Now, our involvement in the field of pediatric cardiology with our patients begins even before our patients are actually born. About 10 times a day, we have a happy couple looking somewhat like this that enters the fetal echocardiography suite in my division, and okay. I'll have to kill someone backstage, and then for some reason this was playing. So, oh, it's playing up there. It just doesn't show up here. Okay, no one's going to get killed. All right. So, they expect to see something like this, a normal fetal heart. Okay, you can see 4 chambers, 2 of the valves, the tricuspid, the mitral are seen. And as we sweep back and forth, you're also going to see the aortic valve, the semilunar valves look good, heart function looks good, the rate looks normal, everyone's happy, right? But sometimes that's not the case. Occasionally you see something like this. Out here you can see that this fetus has a huge ventricular septal defect. Okay? Sometimes you see something like this. The most common cyanotic heart lesion, which would be, see, you guys are already, we should start talking about your fellowship plans already right now. Okay, so yes, this has tetralogy. Oh, well, you're not really that smart. Okay, all right. So you see tetralogy of Fallot out there. You saw that overriding aortic root on top of the ventricular septal defect. It might be a little more complex. This time I won't ask you what you're seeing, but you're seeing transposition of the great arteries where the LV gives rise to the PA, the RV gives rise to the aorta. Sometimes it could be a little more complex, like coarctation of the aorta out here. The ascending aorta comes up, becomes really narrow and causes a lot of turbulence out there. We can diagnose coarctation even in fetal life. Sometimes though, we have really bad news to give people. Out here you can see that, you can see 2 chambers, one here, one there. You can see the 3rd chamber up here, but where the LV should have been, there's nothing. And this is hypoplastic left heart syndrome. Sometimes things are really, really impressive. Like with this patient, the fetus that has a giant tumor, a rhabdomyoma sitting within the heart. So now all these crisp videos prove that we are quite adept at diagnosing all forms of congenital heart disease between 18 and 22 weeks of pregnancy. And in our lab, we are actually moving towards early 2nd trimester transvaginal echocardiography so that we can actually diagnose stuff at around 14 weeks of pregnancy. And prenatal diagnosis actually makes sense on multiple levels. When a couple knows that their fetus, which will be their child in the future, is carrying a severe form of congenital heart disease, they have all of pregnancy to come to terms with that fact. And they are better prepared as parents once the child is born. Now, frequently congenital heart disease is diagnosed in the fetus first, and then an amniocentesis follows and we diagnose that the child has a major chromosomal aberration, like DiGeorge syndrome, for instance, 22q11 microdeletion. Then it's not just a question of having a child with congenital heart disease. All of a sudden now you're talking about a child that's going to have feeding difficulty, might have orophasic problems, immune deficiency, and even schizophrenia when the child grows up to be an adult. We're talking about a totally different discussion. And in some cases, the couple might also make the very tough decision about terminating pregnancy. So doing fetal echocardiography makes sense on multiple levels. But the more important question that we have to ask is, does prenatal diagnosis result in the newborn arriving to the operating room in a better hemodynamic state? That is the true advantage of doing prenatal diagnosis. And we know from all these studies that once the diagnosis is known ahead of time, right, we have like a list that our chief technologist sends out every Thursday. These are the babies that are getting born next week. There's a transposition, there's a baby with truncus arteriosus, there's a baby with hypoplastic left heart syndrome. The NICU knows about this ahead of time. So when the baby comes out blue and not looking good, they're not going to spend time doing superfluous testing. They're going to start prostaglandin therapy right away and not wait for the baby to become acidotic. If the baby is blue, they're not going to intubate the kid, ventilate the kid and prove, oh, the baby continues to remain blue, so it must be cardiac and not respiratory as a cause for the baby being cyanotic. So you avoid all sorts of useless and superfluous interventions. So we have studies from different parts of the globe that prove this. We have a study from the late part of the previous century from France looking only at babies with transposition of the great arteries, and you see that babies that were prenatally diagnosed, were admitted to the NICU much earlier, did not get ventilated, did not tend to be acidotic, and none of them died before being operated on. A similar study on a different cohort, hypoplastic left heart syndrome, a terrible disease actually, shows pretty much the same thing. The kids arrive to the operating room in a better hemodynamic state. And lastly, this from a competing institution in New York City, Columbia Presbyterian Medical Center, dealing with all forms of congenital heart disease, proves the same thing. So yes, if a diagnosis is made prenatally, these kids come to the operating room in a much better hemodynamic state. So far so good. We are getting very good at diagnosing complex congenital heart disease. My colleagues from the intensive care, critical care department are adept at bringing these neonates to the operating room in optimal hemodynamic states. So it stands to reason that the baby should also do well post-operatively. Turns out the picture is not really that clear. The first study that we talked about, the one from France, which looked only at babies with transposition, kind of bore out this message that babies that were prenatally diagnosed had improved post-operative mortality. They stayed for lesser durations of times in the intensive care units, but no major change in post-operative morbidity. And then the waters get muddied a little bit. The hypoplastic left heart syndrome study, now that didn't prove any significant difference in survival to PICU discharge. And actually the study from New York City showed that children that were diagnosed prenatally tended to stay in the hospital for a much longer time than those that were diagnosed postnatally. But this is a much more contemporary cohort. And I would say that if you're in New York City, if you're a pregnant woman in New York City, we kind of take it as a personal insult if complex congenital heart disease is not diagnosed prenatally. I can honestly say that in my previous institution, Montefiore, where I directed the fetal echocardiography lab, for the 5 years that I was the director of the pediatric echo lab, we only did not diagnose 2 patients prenatally. So all these patients are getting diagnosed prenatally. So the kids that get diagnosed prenatally are actually the ones that have very, very complex disease. So the reason they stay for a longer duration of time postnatally or after they have surgery is because they have complex disease to begin with. So these two groups are not comparable, and I would say that prenatal diagnosis definitely helps with post-operative management too, and the results are definitely better in kids that were diagnosed prenatally as having complex congenital heart disease. All right. Now, some people in the audience might think, now, is this stuff even applicable in India? Now, lest you feel that this approach only works in developed economies, let me shine a light on some of the excellent results that have recently been reported out of Kochi from Kerala in India. And this article, actually this report came out in print just last year, so it's hot off the presses if it were. And so they actually looked at 2,000 odd fetal echocardiograms, and in about 550 of their patients, there was congenital heart disease that was diagnosed. And they decided that about 120 of these fetal diagnoses were for such complex congenital heart disease that they needed to deliver those patients at Amrita Institute in Kochi in Kerala. Okay? So if you look at the list of diagnoses, they are not missing anything. They have complex, this probably doesn't, maybe that screen shows it better, but there's complex congenital heart disease out here. Single ventricle, which might mean hypoplastic left heart syndrome. You have your double outlet right ventricles, transpositions, coarctations, pulmonary atresia with intact septum. So all forms of complex congenital heart disease is being diagnosed out there. They're not missing much. Okay? And they're doing all sorts of repairs. Out of their cohort of 120 patients that they delivered at Amrita Institute, you have 1/3 of them that went on to have some sort of neonatal heart surgery. That means within the first 7 to 28 days of life, they had complex congenital heart surgery performed, and they are doing complex work out here. You can see arterial switches, you can see arterial switch with arch repair, even a stage 1 Norwood operation, which is the operation that you do for patients with hypoplastic left heart syndrome, is the first stage of palliation. And follow-up, that means kids that don't need an operation right away after birth, but still need complex work done, like a truncus arteriosus repair, AV canal defect repair, which in my view is the most complex heart operation that you can do, because it really requires a lot of skill to create 2 separate atrioventricular valves when nature just gave you 1 valve. And the results are actually absolutely astounding and excellent. So of all the patients, the third of the patients that underwent neonatal heart surgery, that is just amazing. None of their patients died. So even in an institution in our own country out here, fetal echocardiography can be done, appropriate counseling can be given to these couples, and surgical results tend to be much better if these patients are then delivered at a tertiary level institution. And their rationale for fetal echocardiography is this, that if the diagnosis is made postnatally in an institution where you don't have an echocardiography machine, where you don't have a pediatric cardiologist, then the time taken to get that consultation, to get that echocardiogram, might actually be detrimental to the health of the baby. It is very difficult in some instances to get started on prostaglandin infusion. And then the logistical challenge of then transporting this baby is immense. Just last year we looked at our own results. We published that about how safe transport is for babies that were diagnosed with congenital heart disease and started on prostaglandin and then transported. It's actually not a very difficult process, but the first hour tends to be very crucial. If you start a baby on prostaglandin, in the first hour they have a tendency to become apneic. And you really don't want someone getting apneic on Babasaheb Ambedkar Road in an ambulance. Really? Okay, that's not what you want to do, because you don't want to start practicing your intubation skills right on a roadway. Okay? And that's the problem we had too. So we actually did it the other way around. When we realized that the literature was saying that the first hour is crucial, we put the babies on prostaglandin, wait for a couple of hours or something, the baby declares itself, right? It's either going to get apneic or not going to get apneic. If they don't get apneic, you just put a nasal cannula and send them on their merry way. If they get apneic, then you intubate them. Because again, you don't want to intubate a child that really does not need to be intubated. Now these are results from one institution, and I think some of that has to do with the personality of the division chief out there. If you ever get a chance to meet this guy, you should. His name is Dr. Raman Krishna Kumar, trained at what is widely considered the best teaching institution for pediatric cardiology in the US, Boston Children's Hospital. And he's a man who is singularly devoted to his craft. He's obviously very bright, but he's devoted to building an academic powerhouse. And if you see many of the publications over the past few years in pediatric cardiology, have either come from All India Institute or from the Amrita Institute. Now, when you have that sort of devotion to what you want to do, it's not a surprise that you're going to get these sorts of results. But does that mean that fetal echocardiography is the way to go? It is the way to go, but it's not going to be easy. First of all, we have to get our obstetric colleagues to buy into this. They have to refer you patients. They have to suspect congenital heart disease, or like they do back in the United States, there's a list of 10 indications. Does the mother have uncontrolled diabetes? Do you notice any extracardiac abnormalities? Are there chromosomal abnormalities? Is it an advanced maternal age? Prior child with congenital heart disease? If any of these boxes get checked off, they're going to send the fetus to me. So first, the OB colleagues have to buy into that. And then you have to set up study protocols for a proper fetal echocardiogram. You cannot decide one fine day, okay, we'll start doing fetal echocardiography. You need to know the views, you have to have the appropriate machine. This might take some time. Unfortunately, nature is not going to wait for you to get your act together, right? The incidence of congenital heart disease is 8 in every 1,000 live-born neonates. No matter where this has been studied, that's the incidence of congenital heart disease. And the scarier part is that 25% of these newborns that are born with congenital heart disease have what we call is critical congenital heart disease. That means if the ductus closes, this baby is going to die without some sort of medical management or surgical management. And what do you do out there? Now, we have in our armamentarium a lot of tools, right? We can do a good physical examination, and without any false modesty, I can tell you that your skills are going to be far superior to those of medical practitioners in any other country, because face it, we Indians are very good at physical examination. Our teachers hone it into us, and if not, you're going to have a really bad viva in your third year. Okay. All right. And then we have some other things that you can do. You can get a blood pressure, you can get an ECG, a chest X-ray, and you can get an echocardiogram. But all this starts only when someone suspects congenital heart disease. Are you going to get an EKG and a chest X-ray and an echo in every newborn? No. Someone has to suspect it, and that brings subjective bias. Now, whenever you're talking about mass screening, you cannot leave a crucial element to subjective bias. You cannot leave it to an individual practitioner to say, sounds like this baby could have congenital heart disease. The minute you get that bias in, it's a problem. Someone might be incredibly good at suspecting congenital heart disease. Someone might be incredibly bad. If that is the case, that's not a good screening test. So, leaving it up to individual practitioners is not a good strategy for screening. Can we do something else? Okay. Before that, you might think to yourself, I'm making my mind up if I'm going to devote my entire energy to a particular branch of medicine. Should I pick congenital heart disease? Is it a big problem in our country? Well, here is a recent survey about the presumed causes, of neonatal mortality in India. Recent as in, this was the latest paper that I could find, and it was from 10 years ago. And you can see congenital anomalies, not congenital heart disease, I'm presuming congenital anomalies is there, is actually still the fourth most common in this presumptive survey. Okay, the survey is not presumptive, the causes of mortality are presumptive. Okay, and there's a lot of bias in this because the parents were asked, what do you think your child died of in this survey? And some of these parents were illiterate people. So they might have told the surveyors anything, and then two practitioners looked at that data and decided what the child died of. Even with such a poorly designed study protocol, congenital anomalies in India still is coming up. So the days when we all used to think that prematurity and infections were like the things that we needed to worry about are probably not as applicable. One can also look at this in another way. If we don't study the problem, how are we going to agitate for resources to be allocated towards congenital heart disease if there is no data about how prevalent it is? And the other way is that people are having fewer and fewer children. Some families decide just to have one child. How are you going to be able to look into the eyes of a couple and tell them that their child is probably going to die of a condition that is eminently fixable because we have made the decision that our resources are only going to be allocated towards fighting prematurity or fighting infections? Don't get me wrong, they are important problems, but that's not going to help that one couple. And we have to look at it from the standpoint of every family. Okay? Now, having said that, let's talk about a screening method. We are not going to rely on individual providers to say, I suspect congenital heart disease. Let's see if there's a cheap and effective screening method. I put up this slide because this study is the seminal study which showed that pulse oximetry is a test that can be carried out cheaply and very effectively to diagnose congenital heart disease in the asymptomatic newborn. Now that's a very crucial point that you have to keep in mind. You know, if the child looks blue, if the child has a murmur, if the child has respiratory distress, most of us would eventually figure out something's wrong out here. But there are kids who can be sent home and will die of coarctation of the aorta, will die of hypoplastic left heart syndrome. And this is my favorite bugbear that I bring to all my medical students and torture my residents and fellows. People think that they are adept at detecting cyanosis. Let me tell you, cyanosis is not visually appreciated unless your oxygen saturation is less than 85%. And that's for white kids. If you have African American children, Hispanic children, or the vast majority of children in India, if you think you can visually detect cyanosis, you're going to be wrong. You're going to be very wrong. And stuff like hypoplastic left heart syndrome, truncus arteriosus, total anomalous pulmonary venous return, all by definition cyanotic heart conditions, the saturation is somewhere between 90 and 95%. You're going to miss all those cases. So don't be too proud of just physical examination. We need another tool. Okay? So this study was the first, or among the first I should say, to show the utility of pulse oximetry in diagnosing congenital heart disease in asymptomatic children. Of course, what I should also probably tell you that the reason I like this study is because it was done in the institution where I did my fellowship. So I'm always so proud of showing this study. But it was studies like these that resulted in the American Academy of Pediatrics putting out a consensus statement that they truly believe that pulse oximetry is something that can be used to diagnose congenital heart disease, more importantly critical congenital heart disease in an asymptomatic newborn. If we miss a large VSD, if we miss an AV canal, that's fine. The kid will probably go into high output failure but is not going to die. But obstructed total anomalous pulmonary venous return, hypoplastic left heart syndrome, coarctation of the aorta, all those conditions where you have no murmurs and oxygen saturations between 90 and 95, those kids are going to go home and die. And that's not a good thing. Okay? This screening method will pick up all those kids. So state after state is now mandating that every newborn before being discharged from the newborn nursery has to have oxygen saturation performed. And this slide, which doesn't project very well, is the New York State protocol. Every state has a little bit of a tweak out here in the way it administers the pulse oximetry screening. So every newborn at the time of discharge will have a pulse oximetry done in both the in one upper and one lower extremity. And I won't go into details, but the figures that we are looking for is more than 95% and no difference or a difference less than 3% between the arm and the leg. You quote unquote pass the test, you're able to be discharged. If it's between 90 to 95% and with a difference less than 3%, the nurse waits an hour and repeats it. If it's less than 90% consistently, if there's a saturation difference of more than 3% between the arm and the leg, or if it persists even after an hour, then you cannot get discharged until a cardiologist evaluates you, which usually means getting an echocardiogram. And every once in a while, as a result of this protocol, we pick up a child with transposition of the aorta, we pick up a child with coarctation of the aorta, or total anomalous pulmonary venous return. So this is definitely helping. And this has percolated across the shores to India too. Now the feasibility of this testing has been carried out in NICUs across India. And this report from MAMC reports their findings, but only in sick neonates in their NICU. And what they find is that both the positive predictive value and the negative predictive value of an abnormal pulse oximetry screening is actually very, very good. Now, I did my residency at Sion Hospital, and I actually don't remember ever having signed a death certificate stating that a newborn died of congenital heart disease. So either we were very good, or maybe our patient population was very different, or as is more likely, we were just ignorant about it. Okay? So if you do this test, you are actually going to find the true scope of the problem. Congenital heart disease is more common than sensory neural hearing loss, phenylketonuria, and many other inborn errors of metabolism, but we don't spend as much resources in managing congenital heart disease, and that needs to change. Now, the previous study looked only at children in an NICU. By definition, these are sick neonates. This study, actually, which was done at AIIMS, All India Institute, used pulse oximetry as a screening tool for detecting major congenital heart disease, again in asymptomatic newborns. Extremely well designed study. So there was a priori, they decided how many newborns they would need positive, 160, then they decided they had to enroll 20,000. So usually most of us do it the other way around. We think of a project, we do it, and then we take all our numbers and go to the statistician. And they're like, you don't have enough people. And we're like, we have exhausted all our funding sources, let's do something. That's actually a very bad way of doing research. It should be the other way. And this study was done that way. But there were limitations in this study. As a result of limited number of investigators or funding for investigators, they could only investigate newborns for like 8 hours in a day, which means that they didn't have enough staff for the after hours part of the study. But still, they managed to find a very high incidence of critical congenital heart disease in asymptomatic newborns. Now remember, these are just newborns in a nursery. So pulse oximetry is something that can be absolutely life-saving for infants with critical congenital heart disease, especially those that don't even have any physical findings suggesting that they have congenital heart disease. And this test is actually not very difficult to master or to administer. You need a pulse oximetry probe and it's hooked up to a machine. And in these days, when people are so bright, even this is not necessary. You have a smartphone app that you can use in order to do pulse oximetry. So I know that all of you, or many of you, might be having friends that work at VJTI or IIT and places like that. So it's time for some healthy collaboration between institutions to see if they can design an app that could make this even better at being a mass screening tool. We don't even need that thing out there, which is the oximetry probe. Maybe there's some other way you can do it. Okay? All right. Now you suspect congenital heart disease. What next? Okay, because screening is good for that. It means that I think the child has congenital heart disease. Now, as an echocardiographer, I believe that echo truly has revolutionized the practice of congenital heart disease. Give me a good machine. You should have adequate video sedation so that a child watches that screen. Hopefully, you're watching this screen and trying to figure out what is happening. And given some time, I can guarantee you that we can have a complete diagnosis without the need for other modalities like cardiac cath or MRI in about 99% of cases. This machine, though, is very expensive. It costs about $300,000, right? But again, that's changing, all right? You have machines like this laptop-sized unit, which I've used. One of the things that I love doing is getting congenital heart disease expertise to developing countries, and our organization called Heart Care International goes to Haiti, El Salvador, Mexico hopefully this April, and Uganda. These are the countries that we currently serve. And we take this GE machine, which is a laptop basically, and it gives fabulous quality images. You don't need this big beast anymore, okay? You can have this handheld machine, and at Mount Sinai, there is a movement which I don't think is a great idea, but there's a movement that instead of giving the medical students a stethoscope at their white coat ceremony, which we have at the time of graduation, they're thinking maybe we should give them a handheld echo machine. I don't know if it's such a good idea, because you need to also know what to do with this end of the machine, okay? I feel that it might be good for watching YouTube videos, but you never know, okay? But again, I keep pointing out, maybe there's some bright spark out there in VJTI who can do that, with a smartphone app or something. We use smartphones a lot. Now, I remember as a fellow, I don't know why this is, or maybe I just felt that as a fellow, cyanotic babies always seem to get born at 2 a.m. in the morning. I don't know why that used to be. My fellows have it easy because all their diagnoses are made ahead of time. The plan is Mrs. X is in labor, the baby has duct dependent lesion, and let's start the kid on Prostin, echo kal karenge. Actually, we do speak in Hindi because, 3 of the attendings and 2 of the fellows are Indians, so, We take great pride in that fact, okay? It's also very useful to talk behind your boss in a language that they cannot understand, okay? Somehow didn't work with Dr. Maglani out here because she knew all the languages I used to speak. All right. So, other diagnostic modalities are used sparingly, and now this might come across as heresy, but I tell people that if you know the diagnosis, just don't do a 12-lead EKG. It's useless in the diagnosis of congenital heart disease. It does not narrow down the differential diagnosis. If the EKG is normal, you're not going to say the baby doesn't have congenital heart disease. So I find its utility somewhat limited. Chest X-ray, ditto. Now if there are, maybe in an institution where the dean is a radiologist, this is not a great thing to say, but remember that this talk is about diagnosis of CHD in a newborn. And all those classic findings of X-ray pictures, the snowman appearance or the egg on a string appearance, these are all historical facts which were when surgery was not available. So these were adults or adolescents with transposition or TAPVR that had these classic X-ray findings. In the newborn period, a chest X-ray might not be very helpful, okay? We use MRI frequently in our patients, especially when you want to actually hone your diagnosis, right? If you have a child with total anomalous pulmonary venous return, sometimes echo, I say this with a heavy heart, cannot completely tell you whether all 4 veins drain into a common confluence. Sometimes the right upper vein might just drain into the superior vena cava, and you need to let your surgeon know about that. Otherwise, he or she will do the repair and you'll be left with partial anomalous veins draining to the SVC, which the surgeon did not know about. So we do cardiac MRI a little more frequently than other modalities of testing. Now, in the days of yore, cardiac catheterization was actually the gold standard for doing many of the diagnostic studies for congenital heart disease. Now, echo has completely taken over. This is our biplane echocardiography suite, cardiac cath suite, very expensive, but now cardiac cath is mostly used for interventional cardiology. So, the neonate that actually has to go to the cardiac cath lab is the neonate that has severe valvular aortic stenosis, that the cardiac interventionalist wants to do a balloon angioplasty of the valve wall. You barely ever have to send a patient to the cath lab for diagnosis. As echocardiographers, we would be mortified if a patient had to go for a cath. So you use all these modalities and you arrive at a diagnosis. We all meet every Wednesday afternoon and talk about all the cases that are coming up. And then as a group, we decide about the appropriate intervention. If the patient's mine, I might have a thought and my opinion would carry value. But if the other 11 cardiologists all said, Raj, that's a dumb idea, then we'd have to listen to the consensus. I think that's very helpful. Sometimes the decision at the end of this meeting is to refer the newborn for surgery. Sometimes we say catheter intervention. Sometimes we'll say medical management alone. And sometimes we'd say, great, nothing needs to be done for this baby at this time. Okay? Now, before we go, I want to say that we don't live in isolated castles out there. It's not like the echocardiographers won't talk to the cath lab person or the MRI person doesn't emerge from the radiology den in the ground floor, or that the transplant person is somewhere else. We all work together as a team. This is one place where we work together. So here I am using transesophageal echocardiography to show the interventionalist. This is the atrial septum, that's your left atrium, that's your right atrium. Principle of color echo. When flow goes away from this probe, it looks blue, so there's left to right shunting across the atrial septal defect. The cardiac catheterization person does his or her magic, puts in a nice double device, sandwiching the atrial septum, and your ASD is closed, and I can tell him that he or she did a good job by looking at the position of the ASD device. So we do work together. And sometimes we work in competing ways. Surgeons like to put prosthetic valves, but that requires a sternotomy, right? Now in tetralogy of Fallot, for instance, if the patient has no pulmonic valve because the surgeon took it out, sometimes they are left with free pulmonic regurgitation and the right ventricle gets dilated over the passage of time and becomes dysfunctional. That's not a great thing for the patient. So you want to replace the valve, put a competent valve out there. Ordinarily, or in the olden days, it would have meant another sternotomy. Can you imagine the baby has had one sternotomy for BT shunt, second to do a complete repair, and now third time let's crack the chest open? The parents don't like that idea. So now what is being done is that the cath lab people, who I think are frustrated surgeons at some level, do that valve implantation. So this is what we call the Melody valve. It's a stent, and inside the stent is a bovine jugular vein valve. Now, unlike you and me, the jugular vein of a cow actually does have a venous valve, and it's the perfect size. It's 22 millimeters, which is the size of the pulmonary valve annulus. So the valve is implanted inside the stent. The stent goes on the catheter in the position. With a balloon, you inflate the stent, and voila, you have a valve right where you need it. Now that valve can degenerate or whatever. If it degenerates, we come back again and put a valve again. Patient goes home the same night. Everyone's happy except for the surgeon. I think the surgeon's not happy as a result of this, but everyone else is very happy with this picture. Okay. Now, at this point, I'm going to change gears somewhat. We talked about what is the best strategy to pick up congenital heart disease, right? And once you suspect congenital heart disease, we talked about some of the modalities that we have at our disposal to make the diagnosis. Now let's talk about management of congenital heart disease and what we do as pediatric cardiologists. Now one approach would be to say, okay, we can do these surgeries, we can do these catheter interventions, we can do these EP procedures. And in this current postprandial environment, I think that sort of an approach to talking would be very hazardous. And the lights are also dim, so I really wouldn't know what's happening back there. Okay? On the other hand, I'm going to talk to you about hypoplastic left heart syndrome, because talking about this one case will tell you how we intervene in these patients. Now I hope all of you know somewhat about hypoplastic left heart syndrome. So the left sided structures are small, right? There's no LV, the mitral valve and the aortic valve are either completely atretic or very stenotic, and the ascending aorta is very small. It's amazing that these fetuses can survive, which is what happens when the mother supplies half your circulation. You can have one chamber completely missing and grow up to be a full-term newborn. Once the baby is born and that ductus closes, if nothing is done, it's not a good scene. Okay, what do we do once we have the diagnosis of hypoplastic left heart syndrome? Sometimes, and this is an actual patient of mine who refused my advice about something, but never mind. So sometimes this can play out in a horrible fashion. This patient actually started out with severe aortic stenosis as a fetus. 2 weeks later I see her, the LV is all dilated and poorly functioning. 1 week later, it has become a hypoplastic left heart syndrome. So there's about 10% of hypoplasts that actually start as aortic stenosis and progress to becoming hypoplastic left heart syndrome. So if we ever see this in fetal life, fortunately there's something that we can offer. Aortic stenosis was the problem, right? How about we relieve the aortic stenosis in fetal life? And it can be done. So this is a cartoon, and let this play out a couple of times. It's a gorgeous cartoon. A video, sorry. So here's the needle through the mother's belly, traversing amniotic fluid. This is the chest wall of the fetus. Okay? So let's see that one more time. So this needle has gone through the mom's belly, amniotic fluid, chest wall of the fetus, and gone into the left ventricle of the fetal heart. Then the interventional cardiologist threads in a wire, goes across the aortic valve, and then goes a balloon-tipped catheter across that wire. Once the balloon is in proper position, you inflate the balloon and relieve the fetal aortic stenosis. It's a great procedure, but done in about 3 centers in the United States, and this is a video from Boston Children's Hospital. The numbers are very small. You don't want everyone doing one case every 3 years, because no one would get good at doing it. Okay? So this is a great procedure, but one that really has a 200% mortality risk. You can kill both the fetus and the mother as a result of this. So it's not an expedition to be taken lightly. But if done properly, it can be life-changing. And here's the results from Boston Children's Hospital. See, the numbers are very small. Only 70 procedures attempted. If the procedure was not technically successful, as happened in 18 patients, okay, every baby that was born with hypoplastic left heart syndrome. But if the procedure was technically successful and the baby was live born, about a third of these babies of the entire cohort had a 2-ventricle heart. And that's just amazing. That a child that otherwise would have gone through life with just 1 ventricle now has a 2-ventricular heart. Now, the problem here is that the numbers are very small. We really don't know if these babies would have maybe otherwise also gone on to have a 2-ventricle heart. We don't know. But the very fact that we can offer this modality to our patients is just mind-blowing to me. The other problem, now we talked about hypoplastic left heart syndrome. Should these babies deliver vaginally? Absolutely. If the atrial septal defect is wide open, we deliver these babies vaginally, put them on Prostin, let the mother feed, and somewhere around 5 or 6 days we'll talk about surgery. About 10% of these babies have a very small AST or just an intact septum. If that baby is born, that baby is going to go into severe pulmonary edema and die in a matter of minutes to an hour. So there's many approaches we take out there. One is the so-called exit procedure, where you deliver the head of the baby. So the baby's circulation is still linked up to the placenta, the neck is exposed, and our cardiothoracic surgeon quickly puts in a venous cannula and arterial cannula, hooks the baby up to extracorporeal membrane oxygenation, ECMO, and then the baby is delivered. So the baby goes on ECMO even before the baby is completely delivered from the mother. Or you can take the baby out and rush the baby either to the cath lab or to the operating room and immediately open up the atrial septum. Okay, so that's one way of deciding how to approach birth of babies with hypoplastic left heart syndrome. Once the babies are born, there's one of three things that you can do. Comfort care, which means you basically let the baby die a peaceful death. Now, most hypoplasts are diagnosed in fetal life. If that couple has decided not to terminate the pregnancy, it's not because they want the baby to die immediately after birth. That's out for us. Neonatal transplantation was done a lot in the 1970s because there was no other surgical modality available. But the availability of newborn size hearts is very limited. So a lot of your babies are going to die waiting for a transplant. So the only option that we really have, realistically speaking, is the surgical intervention or the 3-step approach for managing hypoplastic left heart syndrome. What would they be? The first step of the Norwood procedure, nature gave you a pulmonary artery, so you make that pulmonary artery into the aorta. You cut off the pulmonary artery from the heart and you perfuse that with a BT shunt. Okay? So that this single right ventricle is perfusing the aorta or the new aorta now, and through the BT shunt it also perfuses the branch pulmonary arteries. Okay? Now, some babies could be either too small or might have other genetic problems, in which case you don't want to expose the baby to a heart-lung machine and, more importantly, cut off circulation to the brain for about 40 minutes that you have to as part of that stage 1 procedure. In these babies, we do a hybrid procedure. Remember, I told you that sometimes we work together. This is the time when the surgeon and the interventionalist work together, and I'm doing the transesophageal echo to guide them in one crucial step. Surgeon opens up the chest and puts bands across the pulmonary arteries here to prevent pulmonary overcirculation. And since we want to do this non-surgically, the interventional cardiologist goes and puts a stent in the ductus. Okay? So you can achieve circulation to both the body because the ductus perfuses the descending and ascending aorta, and to the lungs from this one artery that nature has given you, because the aorta is unusable in this case. So we have prevented actually this baby from being exposed to cardiopulmonary bypass and also to stopping the circulation, which is part of the stage 1 repair. This is called a hybrid approach. It's used in every baby in the group that published this result, but in our center we reserve it only for babies that are very small or have other comorbidities. We tend to rely on the classic Norwood operation. Okay. Now, there's a steep drop off. That's an unfortunate part. Now, when Norwood started this repair in 1982, the operative mortality was 90%. That means 9 out of 10 babies died. And everyone said this is a wonderful repair. Why? Because otherwise the mortality was 100%. All babies with hypoplastic left heart syndrome died. So it's the only operation where the surgeon actually got congratulated for having 90% mortality rate as a result that he was publishing. Okay. But even now, we can see that a lot of these babies die either immediately after surgery, or we have this first 6-month period where these babies are dying. And we tried to figure out, people in the United States, why are these babies dying? Okay? And sometimes death is in a matter of a day or less than 24 hours. Baby comes in to see the cardiologist, everything looks okay, baby goes home, never wakes up. So what was found was that simple things could clue us in to why the baby was dying. The pulse oximetry reading was too low, but no one picked it up. The baby was not gaining adequate amounts of weight. So now, even when the babies are in the hospital, we have our own nutritionist who goes over this nutrition algorithm in excruciating detail with the parents. Even before they go home, if the babies are not eating so many ounces of formula or express breast milk, this baby is going to go home with a feeding tube. And the people in Wisconsin Children's Hospital were the first to really look at this in a formalized way. Our patients are enrolled in what is called as the single ventricle protocol. They get a weighing scale, a pulse oximeter. So if they don't gain enough weight or gain too much weight, or if their oxygen saturation is low, they're going to call the nurse coordinator immediately. We'll see them either the same evening or the very next day. A nurse actually goes home 2 days a week to assess the child, and they come and see the cardiologist in the hospital once a week. So it's such degree of very careful, close follow-up, which has ensured that these patients actually have very low interstage mortality between stage 1 and stage 2. When the Wisconsin group followed the home monitoring protocol, they didn't lose any patients. And before they instituted that protocol, they lost about 15% of their patients. So it is such degree of merging a lot of specialties and close follow-up with these patients that ensures that they can come up to the second stage. Now what is the second stage? Nature just gives you one ventricle. You got to make that work as the left ventricle. So you cannot allow venous blood to get into the heart. Okay? So at around 4 to 6 months, you disconnect the superior vena cava and connect it directly to the pulmonary artery. This is called a bidirectional Glenn procedure. Works very well, mortality rates are super low. And then at around 4 to 6 years of life, that IVC still is connected to the heart. So you either disconnect it from the heart and put a tube between the IVC and the PA, or make a tube between the IVC through the right atrium, connecting it to the PA. So at 4 to 6 years of age, your heart is completely separated out from the systemic venous return. It passively goes into the lungs, and that's the problem. That means there is no pump in there. So you are relying on pristine lung health to ensure that this operation succeeds. If your lung pressures go up, your veins cannot drain as easily into the lungs. So you're going to be left with no cardiac output, and that's a huge problem that these patients have. So the next stage of research, it's not actually applicable at this point, is to put an artificial pump in circuit on the right side to overcome these issues. And as a result of these modifications, a condition that is absolutely incompatible with life, when the ductus closes, there's no circulation going in to your systemic side. So you're going to die if nothing's done. As a result of these interventions, we are at a stage where at the end of about 5 years or so, or this is probably going up to 8 years, about 90% of your standard risk patients are surviving. They are surviving as a result of it. And if you're high risk, that means if you're low birth weight, if you have chromosomal problems, if you have a genetic disorder, the survival rates are still not as great as this, but not bad. 65% of these patients are now surviving at the age of 8 years or so. But that's not to say that these patients are the picture of health. There's lots of issues. You put a child on bypass for 3 times, right? And the first time is when the child is a newborn. You're cutting off circulation to the brain for the time that you're repairing the arch. You're going to worry about neurodevelopmental issues. Lung health is a big problem, and many of our patients come down with what is called as plastic bronchitis. They're basically coughing up casts of their tracheobronchial tree. They can have chronic liver problems like cirrhosis and even liver neoplasms, decreased bone density and short stature. And the right ventricle was never designed by nature to work as a left ventricle, right? So at some point in almost all of our patients, that ventricle is just not going to work, and these patients will have to be listed for transplants. Unfortunately, the transplant survival for patients that have congenital heart disease is not as good as for those with cardiomyopathy. So these patients are surviving, but they require a lot of help, not just from cardiologists, they require help from pulmonologists, GI specialists, from endocrinologists and hematologists. So we have a single ventricle survivorship program that involves all these specialties. Okay? And this is not a cheap endeavor. Even in the United States, we would say that's a pretty good cost. $250,000 to do a stage 1 Norwood. That's a lot of money for these patients. Okay. So it involves a team like you see out here. I am taking the picture, so I am not in it. I still work at the institution. But this is our awesome surgeon who does such a wonderful job with our patients. Okay. Quickly to look at India, because we need for people amongst this audience to be the next generation of pediatric cardiologists and surgeons and anesthesiologists and critical care physicians that help us take excellent care of these patients. I'm just going to skip over this slide just to prove what the magnitude of the problem is. If you just take a crude birth rate of 27 per thousand as exists in India, every year you have almost 2 lakh children being born with congenital heart disease, if you believe the incidence rate of 8 in 1,000, which is true across the globe. And we spoke about a quarter of these babies having critical congenital heart disease. So each year, 50,000 newborns in our country need some form of neonatal cardiac intervention. And clearly not all of them are getting that, because 10% of the present infant mortality in India is probably from congenital heart disease, which is unrecognized, unfortunately. Okay? We won't go over that slide either. But what do we have right now? And this slide is a little dated from 2015. A lot has changed in the past 10 years. Okay? At that time, there were 25 pediatric cardiologists in India. I really missed a golden opportunity to come back. I would have been something by now. Okay? Only 10 to 12 pediatric cardiothoracic surgeons. And only 14 centers offering cardiothoracic surgical services. And if you go by the American College of Cardiology recommendation that every 5 million people should have one center, there should have been 200 centers in India. So there's a lot of catching up to do. And there were only 6,500 surgical procedures being done in that era. And you know that even if you only did critical congenital heart surgery, you would be doing 50,000 cases a year. We're not even talking about babies that need ASDs closed, PDAs ligated, not all over that. We're just talking about critical congenital heart disease. But the centers are definitely increasing in number, but there's a skew. As you can see, the centers are gravitating towards major metros, but also major metros which have the paying potential. Very few centers, in fact at the time of the 2005 report, just one center was in a government hospital, which was AIIMS, Ames Hospital. Everyone else was private. But heart disease, last I checked, did not affect only the rich and wealthy or the well-to-do, it affects everyone. So I would suggest to you that a lot can be done, and it would involve all this. Let's have screening programs to figure out. Just let's say, tell the politicians this is a problem. The pulse oximetry thing didn't come because doctors were agitating. We are always agitating about something. It's usually for better pay, right? But it's because parents who had lost children went up to Congress. And when a mother that's lost a child comes up and speaks before Congress out there, it sends a powerful message. I don't think our politicians have thicker skins than those in the United States. If physicians and parents, especially parents that have unfortunately lost children, are out upfront and agitating for these services, they will be provided. No human being can be so immune to the suffering of others. But we need to have the data. You just can't say, well, I, Rajesh Shenoy, think this is a big problem. People will say, well, that's wonderful. When's your flight back to the United States? Okay. We need improved diagnostics, including autopsy and genetic linkage. Truly, there might be things that are different in India as to what the genetic linkages of these conditions are. And we need to train a hell of a lot of people, and not just doctors. We need nurses, nutritionists, pharmacists. I cannot emphasize how important sonographers are. I don't do most of my echoes. All those beautiful pictures were obtained by my sonographers. And we need availability of services across the board. I won't talk a lot about this because I see that Dr. Devi Shetty is the speaker tomorrow, and that guy has done more than I can even talk about addressing this particular field. So finally, thank you very much for having me over. I cannot say more about, I'm happy to have come from this place, but I'm also happy to be working here in this building overlooking Central Park, where sometimes I go for a jog, just to say that medicine cannot be all about always being hyper about everything. Sometimes you have to let your hair down and enjoy life too. Otherwise, you'll just be dead very early. So, it's a great crowd. I enjoyed speaking before you. I hope you enjoyed listening to me, and good luck for the future.
Friends, I'm sure you have witnessed a wonderful, lucid talk on pediatric cardiology and its perspective. As I think you must not do cross-talking when someone is speaking to you, because I'm speaking to each one of you. So I want your attention. I think he deserves the applause once more. Where is Rajesh?
Thank you.
So, the reason why I said once more, he's come from half a globe away on his own expense, landed just in the morning and is here, and I thought he might be actually a little sleepy, but I think I should apologize that I was sleepier than he was. Not because I was not enjoying the talk, but because the atmosphere is too cold. It's chilly out here, but y'all are with jackets so you don't feel cold, okay? That's the reason. Now also let me tell you, Rajesh was an extraordinary student of this college as a postgraduate in pediatrics, and he was wonderful in the way he worked with lot of amicability with his team members. I remember Rajesh being one of the persons who used to always be cool, calm, composed when there was an emergency, and I would in fact sometimes ask him, Rajesh, how you manage to keep your cool? And he would say, Dr. Manglani, it's just that I am like that. That is his quality, and I'm sure we had a great time listening to you. Enjoyed a lot. Thank you for being here. Thank you on behalf of my college, my students, your college, and Mumbai city, I would say. Thank you.
All right, I have to tell you why I didn't do Hemonk.
I must listen to this.
Because my aim, of course, as all aims go, it never comes to fruition, was to train and come back. And if I came back as a hematologist, I would be competing with Dr. Manglani and Dr. Lokeshwar. And I thought that would be the end of any practice right there. So that is one of the reasons.
All that he said was in lighter vein. Don't take it seriously.